All right, I think we can get started now since we're waiting on some other people to join us. But today, Dr. Corrala will talk about automatic tube compensation, and this will be an open format webinar. You can interrupt with questions anytime, either by turning on your mic or raising your hand or typing in the chat, whichever you feel comfortable. If you like to participate, you can raise your hand and I can turn on your video if you like as well. Please follow us on icureach.com, and under the events tab, you can check us out for our future ventilator rounds and webinars. The next one we have scheduled is on July 12th at 1 p.m. Riyadh time, and we will be talking about treatment in septic patients. And please don't forget to share this event with your colleagues. It will be available on YouTube after we are done and on the ICU Reach channel after. And please don't forget to support and reach out to contributions and subscriptions on our YouTube channel. But I'm going to pass it off and start our webinar.
Thank you very much, Keely. So I see Keely Faisal Rawaga. Why don't you admit him into the meeting, and also Ali Al-Janubi. And Sufyan, you see Dr. Sufyan too?
Do you want me to hit allow to talk or promote the panel?
You need, exactly. Make them panelists. And again, this is open discussion. So if anyone would like to be admitted as a panelist, please raise your hand and Keely will admit you as a panelist. Now, once you're in the panel, you'll be able to unmute yourself and talk at any time, or turn on your video also. So again, this is going to be open format. I'm going to discuss in details automatic tube compensation, so we understand it as intensivist, and you'll be able to manage the patient on the ventilator in a better way once you understand how is it implemented, how we do it, how does it affect our pressure on the ventilator. And of course, I'm not going to talk about evidence behind it in terms of whether it's associated with good outcome or not. We're just trying to understand what automatic tube compensation is and how we set it on the ventilator. The name may be different from one ventilator to another, but the most common name is ATC, which is automatic tube compensation. You may see other names like airway resistance compensation, or any other names. So we're going to just explain the principle or the principles behind it. So first, again, everything is based on the equation of motion. And the equation of motion is the formula that equates the pressure on one side with what's happening in the respiratory system on the other side. So the pressure should equal the flow multiplied by the resistance. And the resistance, once we intubate the patient, would be number one, ET tube, and number two, the natural airways, the trachea and the bronchi. And this is the resistive work that the patient or the ventilator need to overcome. And then there's elastic work that needs to be done by the ventilator or the patient. And it is related to the volume that is set or delivered and the respiratory compliance. So in volume control mode of ventilation, what we set on the ventilator is the volume. Of course, if we set the volume, that means that we're setting the flow also. So those are independent variables. And the pressure on the ventilator will be the dependent variable. meaning that the pressure will depend on, number one, the airway resistance, and number two, the lung and chest wall compliance. The pressure will be variable. However, the flow and volume will be fixed. So that's why we call those independent variables. And this one is dependent variable. So if the patient is not breathing, he's not able to contribute to the pressure. However, if the patient is started to breathe, is initiating and contributing to the pressure generation during the breath, at that time, the pressure will be variable. So we generate pressure for the patient. Since the flow and the volume are fixed, the ventilator generated by the patient will be less, by the ventilator will be less. And this is how volume control mode of ventilation function. Now, in pressure modes, whether it is pressure support or pressure control, what we set on the ventilator is the pressure. So that is the independent variable. It is set on the ventilator. And then the flow and the volume will be dependent variables. And what are they dependent on? They are dependent on the resistance and the compliance. So those will be variable as the resistance and compliance are changing. And of course, the patient will be able to breathe. And if he's contributing to the pressure generation on this side, that will affect directly the flow and the volume. So if the patient started to breathe, he will have more volume delivered because the pressure is fixed. So I hope this is very clear. If there's any question, I can answer. And if this is clear to everyone, let me move to spontaneous breathing. So if we're not supporting the patient, the ventilator pressure is 0. We're doing spontaneous breathing trial. When a patient who's intubated, the patient has to do the work. So the independent variable is the patient's pressure. And the dependent variables would be also the flow and the volume, meaning that the flow and the volume will be variable dependent on how much the patient is generating, how much, excuse me, how much pressure is the patient generating. If the patient takes deep breath, it will generate higher flow and higher volume. There's no ventilator pressure here. Now, if we add ATC, automatic tube compensation, to the spontaneous breathing, now the pressure generated by the patient will still affect the flow and the volume. However, the ventilator pressure that we set is set to overcome the airway resistance caused by the ET tube. So we're going to overcome this part only by the patient's ventilator, by the ventilator. However, the flow is variable. And you know that the resistive work that the patient needs to do is dependent on the flow, number one, and number two, the resistance of the airways. So we change that pressure in relation to the flow that is generated by the patient. This way, we can overcome all the resistive load that is imposed on the system by the ET tube. And we're going to explain it in a different way. So this is the patient. The natural airways here. We have the AT tube. And if you measure the pressure before the AT tube here, and after the AT tube, you will see that there is a pressure drop. This pressure drop is related to the pressure needed to overcome the resistive load of the tube. That resistive load is related to, number one, the length of the tube. Number two, the diameter of the tube. And number three, the flow of the air through the tube. So there are three parameters for the resistive load. What type of tube that we're using and how much flow we're moving through the tube. And the drop in the pressure between this point and this point here is representing the pressure required to overcome this resistive load that we have. Again, the patient's inspiratory flow is highly variable. It's different from one breath to another. So when you set a pressure support, let's just take this pressure here, let's just say it is 5 centimeters of water. You would say, well, I can set a pressure support of 5 centimeters of water during my spontaneous breathing trial, and then I can overcome the airway resistance or the artificial airway resistance. Well, that's partially true because number one, that pressure could overcompensate or undercompensate the resistive load because of the variability in the inspiratory flow of the patient. The flow may even change within the breath. The patient may actually take a larger breath within, larger flow within the breath. So you need something that is measuring the flow instantly and delivering the pressure based on that flow and based on the resistance of the tube. And that is the ATC. Now, without having ATC, what you see here that the patient has to do the work. So you can see the two arrows here. And the first one is the work that the patient needs to do to overcome the compliance of the respiratory system and the resistance of the natural airways. But there is a part of that pressure here is pressure that the patient would do to overcome the resistance of the ET tube here. And when we set the ATC, we take this away from the patient and give it to the ventilator. So again, this is the pressure that the patient has to do. All what we do with ATC is just take away this from the patient and give it to the ventilator. And not only that, we adjust this pressure from breath to breath to overcome the resistive load of the ET tube and the variable flow through that ET tube because of the variability in the inspiratory pressure of the patient. Inspiratory flow of the patient, I'm sorry. So you can see here that this pressure would only overcome the resistive load of the tube, which is related to the length of the tube, the diameter of the tube, and the flow of the air through the tube. How do we do this? The ventilator measures the flow and continuously calculates the pressure drop. And you need to tell the ventilator what is the size of the tube that you are using and how much you want to compensate. And we'll see that when we simulate this. But if you put the size of the tube and whether you are using ET tube or tracheostomy tube, because the length will be dramatically different between the two. And the machine will calculate the resistance of the tube, and it will measure the flow. And as the machine is measuring the flow, it will be able to determine how much pressure drop between the proximal portion of the tube and the distal portion, and will generate pressure equivalent to this pressure drop. And then that pressure will be used to overcome the resistive load of the endotracheal tube. And let's just see this. So in the top part here, what you see, this is pressure over time. The solid line is the pressure in the circuit. The dotted line is the tracheal pressure. And you can see here that there is no peep. Peep of, I see it's like if this is the zero line, probably slightly higher. Okay. But forget about the peep, because you can understand this by looking at the circuit pressure here. And you can see that the patient is generating deeper pressure here. And the pressure in the circuit goes up to 5 centimeters of water. So this is set at pressure support 5 centimeters of water compared to the bottom graph of ATC that is set automatically with no pressure support. So you can see here the breath is initiated. The patient drops the pressure here, and then the machine will be triggered, and the machine will give pressure support of 5 centimeters of water. So that will be fixed. It's not going to be variable, because you're setting that pressure on the ventilator throughout the inspiration. And once the machine is triggered, we have this pressure of 5 centimeters of water. Now you can see here in the early part of the breath that patient actually generated a huge pressure here to overcome the airway resistance. And that pressure support was not enough. So this is undercompensation. You're not able to compensate for the resistive load of the ET tube in early inspiration. On the other side here, you can see at the end of inspiration, you're using too much pressure. You don't need that much pressure to compensate for the resistive load of the airways of the ET tube. So you're causing overcompensation here. Now compare this to the bottom graph here. So here we have ATC on, and ATC is just pressure support, but it is variable pressure support. And the level is not determined by you. It is determined by the machine. And how does the machine determine that pressure? It will measure the flow. And because you're giving the machine the size of the ET tube and what type of artificial airway you're using, whether ET tube or trach, and then the size of the trach versus the ET tube, the machine will be able to calculate the pressure. And look at this. In the first case here, you put it at 5 centimeters. But in the second case here, you can see that the machine determined that early on, you need close to 8 to 9 centimeters of water to overcome the resistive load of the endotracheal tube. And you see that's well compensated now. So that 5 centimeters of water was not enough. Now, as the inspiration continues, the flow goes down. As the flow goes down, there's no need for too much pressure. So you can see the automatic tube compensation pressure, or the pressure support, is decreasing. So we have a pressure support started at 8 to 9 centimeters of water in early inspiration, but at the end of inspiration, it goes very low and then reaches zero here. And you can see the patient is not doing much efforts here. So in other words, he's very well compensated. Now, a lot of ventilator graphs will actually show you the estimated tracheal pressure. You will see either green line or a line of different color, estimating the tracheal pressure. And the solid line will tell you about the circuit pressure, or the pressure of the airways. And you can see here that the difference between the circuit pressure and the tracheal pressure is the pressure generated by the machine to overcome the airway resistance. Now, this pressure is not only in inspiration, it is also in expiration. And this is not known by a lot of intensivists, that as we support the inspiratory part of the breath with positive pressure, we create pressure to overcome the airway resistance of the tube. And you can see it here. In expiration, we can drop the pressure. So it would be ATC the other way. We can drop the pressure. And by dropping the pressure, we can generate wider gradient between the alveoli and the airways. So you can help exhaling faster. And it will be of specific importance in those patients who have auto-PEEP. Pressure difference, and then you'll be able to exhale more effectively, and you'll be able to empty the lungs more effectively. So it might help you in patients with dynamic hyperinflation syndrome, or patients with auto-PEEP, meaning that those asthmatic patients. And you can see that the pressure goes below the PEEP here. If this is the PEEP level, it will go below the PEEP. That negative pressure and creating larger gradient for the airflow, the expiratory airflow. So before, it's different from one machine to another. So in this specific ventilator, the way you set ATC is by selecting first what type of the tube you have. Are you dealing with ET tube, or are you dealing with tracheostomy? And then after that, you need to select the size of the tube and how much you want to compensate. Do you want to compensate 50%, 80%, or 100%? And there is no reason why it should be less than 100% when I do SPT for those patients. And if I'm selecting ATC for those patients, why should I do 80% or less? I usually select 100% for all patients. So let the machine decide about the pressure. Now, if you ask why we have this range, because you may overshoot sometime the pressure. When you say 100%, the machine may overshoot the pressure. So you can probably, if you take a look and see it's too much pressure, you may go down to 80%. But I don't see a reason why it should be less than 80% in terms of compensation. And in specific weaning protocol for those patients on adaptive support ventilation, the recommendation by the protocol is to set it at 50% compensation. I really don't understand exactly why it should be set at 50% and not 80% or higher. But I just wanted to mention that some protocols may suggest a lower percentage. And then you need to turn it on. You switch it on and it is activated. Once it is activated, that's what you see. And this is on the Drager machine. You can see that blue line, the green line representing the tracheal pressure. And this is imaginary, by the way. It does not measure it. Okay. And the dark area here represent the airway pressure and the pressure at the Y piece. And this is measured. And you can see the difference here. This is the compensation. The blue circle here that you see is the compensation that is imposed by the ATC when it is set on. And you can see in the red circle here how the pressure goes into negative pressure in expiration. Now, I want to say that you cannot on the tracker, differentiate between inspiratory ATC and expiratory ATC. But in some other ventilator brands, you may be able to do that. You may select how much you want to compensate during inspiration and how much you want to compensate during expiration. So now I'm going to switch to the simulator, but I want to give you an opportunity to ask any questions before we simulate the ATC on the ventilator. Do you have any questions, Keely?
No, we haven't had any questions.
So, Faisal, is this understood? Do you want me to go over any specific?
Yeah, it's clear. It's clear. Yes, it's super clear. Thank you.
Excellent. And let me. What about you, Ali? How are you doing?
Alhamdulillah, bkhair. Thank you, Dr. Mazen.
It's good
I
to
think the
have you
concept
here.
is my pleasure.
Okay. So let me bring the simulator, and I think it will be interesting to see it. And I'm going to use the Hamilton for this. And let me just share my screen. And I'm going to share my screen. Tell me, Keely, if it is, if you see my screen.
It's clear.
I can see your screen on the Zoom, but not on the YouTube.
It may take some time before it goes to the.
Oh, it's now on for YouTube.
Okay.
So we're all good.
Excellent. Very good. Thank you. So let's set it first. I'm going to change the mode to spontaneous mode. So let the patient breathe on his own. And first, let's just give him pressure support of 10. And I'm going to give him some strength. Okay, and see what happens here. So all right. So you can see here. So this is a patient. Let's just ask him to start breathing and give him rate of 18. So this patient is breathing on his own. I just want to get out of the apnea ventilation. Okay, and now we started. Okay, high tidal volume. So let's just disable the alarms. Here's the tidal volume. And I'm going to use a large tidal volume, so for just simulation purpose, but I don't want the alarm to go off. All right. So all right. So let's take a look here. So you have this patient who's on pressure support mode of ventilation. You can see he's on a PEEP of 5. So the pressure goes from 5 all the way to 15 and stays at this level throughout inspiration. Take a look on the flow. The flow is decelerating, goes up to the maximum inspiratory flow, decelerates. Once we reach 20 or 25%, whatever set on the ventilator, the pressure is released. And this is just pressure support mode of ventilation. Okay. So if I have this patient on SPT, usually what you do is you select pressure support of 8. And this is what we do in our ICU, should be pressure support of, if you don't have ATC on, it should be pressure support that overcome the ET tube resistance. So you would say, if the tube is 6, I'm going to select pressure support of 8. If the tube is tube size is 8.5, I may not need 8 centimeters of water. I only going to select 6 centimeters of water. And this is our case here. So I'm going to use 6 centimeters of water. But notice that the pressure is constant during inspiration from the start till the end. It's the same pressure we're using. And the aim of this is overcoming the resistive load. Okay, take a look on the flow. What do you notice? The flow is high in the beginning and then goes down. What does that mean? It means my resistive load is different. It's higher in the initiation of inspiration and then is lower. And there is no way I would actually go down the pressure here. And this is how ATC might help us. So we go to additions, and you can see here it says tube resistance compensation. So it's called TRC rather than ATC. As I said, different ventilators may give you different names for this, but the principles are the same for all. And here we're using 82, so I'm going to select the 82. And then you're going to select how much tube size, and we said it's size 8. And then you want to select how much you're going to compensate. So for tube size 8, compensating 100%, and it is 82. Let's just apply. Okay. And take a look here. What happened? Now, remember, I did not take off the pressure support yet. Okay. I just wanted you to see how does it look when we have the ATC on. And it is very clear here. Okay. So the orange color is the trachea pressure. And this is the same pressure that we had before we put the ATC on. So if I remove the ATC, okay, you can see that this is the yellow line similar to the orange line here. So let me put it back on so you can differentiate and see the difference. And you can see that now the orange line is the tracheal pressure. The ATC pressure is added to the circuit here. And you can see that that pressure goes up higher than the orange line. This is the pressure that is added at the start of inspiration. But notice what happened. It goes down gradually after that. It is small percentage because you don't need much pressure. Now let's just take off, because the purpose of the ATC is to eliminate the pressure support. So if I turned the ATC on, I don't need to keep the pressure support on. So I'm going to remove the pressure support and take a look on what happens. So you can see that, again, you will see differentiation between the tracheal pressure and the circuit pressure, which is the yellow line here. And that circuit pressure is slightly higher than, you can't see the difference, okay? And this pressure is, again, related, number one, to the size of the tube and the length of the tube, and number two, to the flow of the patient. So let's change the flow and see what happens to that pressure. So I can change the flow of the patient here. So let me go up higher on the flow. I'm going to go up to 20. So you can see now, since I have higher flow, I need higher pressure. You can see that clearly here. See the higher pressure here? So it's increased to overcome the resistive load. Now it is higher. Why? Because the flow is higher. Again, I'm using resistive load for a combination of the resistance of the ET tube number one and the flow that goes through the tube number two. Okay. Now, if the patient takes higher, deeper breath, let's go to inspiratory effort of 30 liters. We can clearly see now the flow is higher. What happened to the pressure? Automatically adjusted. So the pressure is automatically adjusted to compensate for that higher flow. And this way, you don't have to adjust anything. As you see, the pressure is adjusted, and it goes up to 10 here. You can see it went up to 10. Why it goes up this way, not high very on? Because of the flow. Look at the flow. The flow goes up gradually. It's sine wave because it's spontaneous breathing now. It's not pressure supported breath anymore. And then that pressure goes up gradually. As the flow goes up, the machine continuously measures that flow. As the flow goes up, the pressure support goes up gradually with that increase in the flow to overcome the resistive load of that ET tube that is imposed on the ventilator. And if you go back again to pressure support, if you do pressure support of 8, okay, I just wanted you to see the decrease in the pressure. You can see here, I have pressure support of 8, and I have ATC above that pressure support. You can see it here, that everything here is ATC. But look how clearly you can see that the drop in the pressure is not only in the ATC is not only in inspiration, but is also, let me take off the alarm. How much minute ventilation we have? Is it higher than 24? Okay. So you can see that in inspiration, this is the pressure that was added to the circuit. This is the trachea pressure. In expiration, this is the pressure drop that is caused by ATC. So this is helping the patient to exhale more efficiently, and it will help you in patients with dynamic hyperinflation or autopsy. So I think that's all what I have, and I will stop here and see if you have any questions or anything that needs to be clarified in more details. Faisal?
Yeah, thank you, Doctor, very much. I want to ask if we have to do some maneuvers before we apply the ATC, for example, to suction the tube or not, or something like that. We have a protocol for that to make sure not to have a plug inside the tube.
So thank you very much, actually. Very important question. This takes me to some of the problems of ATC. So you should not assume that ATC is going to take off the resistive load completely. If you have any secretions, any blood clots, or any mucus accumulation within the tube, the ATC cannot account for that because it doesn't see it. And you're only inputting into the system, number one, the size of the tube, number two, the length of the tube. And the length, by the way, is fixed. It's either ET tube or tracheostomy tube. So it's either short or long. And then the machine will measure the flow. So any increase in the resistance of the ET tube is due to external factors, such as what you mentioned, secretions, blood, or anything like this. The machine doesn't see it. And then the patient needs to exert extra effort in order to overcome that resistive load. That's a great question. Thank you very much. So frequent suctioning for those patients would be still required.
Thank you, Dr. Khairallah. What I can understand that the ATC will provide more tailored support to the patient depending on the tube and the flow. But outcome-wise, is there any difference? Like, is it more physiological and comfortable for the patient to go to ATC by comparison to the classic pressure support? Or it is by the end, it's the same as long you choose the proper support in the pressure support settings?
Correct. So that's why I mentioned in the beginning that I'm not going to present the studies that looked at outcome. There's no solid or there are no studies that show me that if you do not use ATC, your weaning process is going to be much more prolonged. There are some studies showing some benefits of ATC. What I would say, it is very physiological and it helps the patient. It chooses the pressure needed throughout inspiration in more physiologic way, but it really doesn't affect the outcome that you're going to extubate those patients faster, quicker, or it's going to make the patient more comfortable. The studies, we don't have studies that show us this in a good way, but I wanted to explain, that's why I said I want to explain it as one of the maneuvers that we have and we can utilize for the comfort of the patient. It does not harm the patient, of course, but it is very physiological. Any other comments or questions? Katie, is there anything on YouTube?
No, there is no questions on YouTube.
Okay, so if not, we can conclude. And I think there's going to be a quick feedback survey. If you have any suggestions for topics for next ventilator round, please submit that through the survey, and I'll make every effort to fulfill any requests. And we're going to do this every 2 weeks, hopefully. So till then, thank you very much and see you next time.